See, this is supposed to be Kisumu. Nice place, right? Sorry, UK, not Kisumu. It's what going for randomized trial, and it is a project funded by the National Institute of Mental Health. And it's trying to give time to a young state. Now, the objective of my presentation today is one problem, not hiding behind the so, not hiding behind it. So, so the objective of this presentation is that some of the finding studies uh, that a collaborative team has been undertaking in Kisumu County Referral Hospital for the last 5 years. And very specifically, I just want to touch on the sociodemographic and health characteristics of our participants who was screened positive for major depressive disorder and post-traumatic stress disorder. Now, just a brief introduction. We do know, of course, that the burden of untreated mental health, the mental disorders is high, and there is a very significant contribution to disability. And the damage due to mental disorders increased from 16.9 in 2000 to 20.6, making it one of the leading causes of disability mortality. And most of the burden has been found to be in low and middle income countries. Now, among the top three mental disorders in the GDP study of 2019 was depression, anxiety. Uh, just a brief on COVID-19 time. It was found that between 2020 and 2021, COVID-19 was associated with 27% increase of major depressive disorder. So, and anxiety, that is the COVID era. Now, which there are a lot of pie charts, diagrams, I'll just very briefly point out that the African region is actually leading in depressive disorder compared to the other regions of the world, with the females leading in this category. Now, 35% or more of the people with serious mental disorders in the low and middle income countries never treatment. And this has been going around for some time, this kind of figure. And in the last 15 to 20 years, a lot of work has been done to try and bridge this gap in treatment, the mental health intervention gap. And there's been research demonstrating the efficacy of evidence-based low-cost depression treatment, particularly for depression, delivered by non-specialist personnel with low resource settings. Of course, there's a lot more to it than just that. There's a question of training, there's a question of continued supervision, and we know that WHO have done a lot of work, and a lot of work has also been done by the group in India on this. And this is where our project is on. And very quickly, one of the problems that we have, apart from all those social determinants of mental health that we talk about, poverty, and we also have a deficit in resources. And this includes physical as well as personnel resources. So this diagram just shows some of the projected deficits in personnel that is providers manage mental health. Our levels of major depressive disorder in primary healthcare settings are relatively high at 26%, according to studies done by the TEG group and PTSD, according to a study done by another of our colleagues, Dr. Ned Ongeri and others who you know, like Professor Otieno, So we do indeed have high levels, just in the primary, and these studies have been done for a long time. Even when I was doing my MA, there were still people showing that go to any primary health care setting, that is this outpatient clinic people walk into, that we have a very high prevalence of mental health disorders, particularly depression, anxiety, and even in the pediatric uh, area that you will find children, a lot of children with mental health disorder, which are not detected and not treated. And this is where our study comes in. So our study, just to briefly summarize, is that the overall goal was to bridge this mental health intervention gap by integrating within existing healthcare facilities non-specialist delivery of evidence with evidence-based treatment for depression and PTSD. We picked on depression and PTSD, some of those disorders that have been shown have a high prevalence, but also have a high impact on people's lives, people, and community. So we have two interventions. That is, one is interpersonal therapy. IPT delivered by non-specialists. By non-specialists, we mean people who are not specialized in therapy, talk therapy, like psychologists, clinical psychologists. We also, on the other hand, we had the intervention using an SSRI, fluoxetine in this case, which is actually the WHO list of essential drugs, and which has not been used very widely. And we are trying to show that even where there is no psychiatrist, no clinical officer psychiatrist, this drug can still be safely used, and it is actually safer than what the level 3, level 4 hospitals, you all know. So we were saying this is a safer drug, yet we are leaving it only, they are saying it can only be prescribed by psychiatrists. Can nurses and clinical who are not specialized in psychiatry also be trained to prescribe safety and effective? So we have very many specific aids, but I don't want to go through all of them. The last but we did start to, in one trying to determine the effectiveness of non-specialized delivery interpersonal therapy and fluoxetine for major depressive disorder and PTSD, where both those therapies are, there's evidence of efficacy in both depression and PTSD. And in A2, where we are still to analyze data, we try and investigate the mediator and relationship between treatment and remission. We're still doing a lot of analysis of that. And then to identify sociodemographic demographic and moderator of the relationship between the treatment. Again, we're still doing that. So basically, what I'm just doing is bringing the results and the cost effectiveness. So, our study method, the study site, like I said, is Kisumu County. Particularly, our participants were recruited from Kisumu County. It's a referral hospital. We also get teaching at maybe at a hospital. Luba Health Center is one of the local health centers. We also try to recruit from JTRH. 10 minutes ago, I'm going to do it in good time. So I'm not going to discuss that. So let me talk about the study design very quickly. Sequential, multiple, assignment, randomized trial. And I'll show you a diagram. So just hold it there to show what that means. It's a hybrid one. That means effectiveness, prioritize, and then implementation. And how do we do the recruitment? We did health talks in the facility in Kisumu County, we did contact all that you have these symptoms, contact this group. We had referrals also from other outpatients, so we also had awareness in other parts of the hospital. What of mouth turned out to be one of our best recruiters, that participants who had recovered from the treatment went and told their friends. And they came in the end, it became our biggest recruiter. We had some social costs like pregnancy because of the use of antidepressants, respiratory, alcohol and drug use disorders, bipolar because of fluoxetine, and acute suicidality. But the inclusion criteria has to be you're within the region to Kisumu, and you're also an adult aged over 18 and not already on any other form of treatment. Now, I think I will explain about sequential. It means that you participants who are randomized to two arms, IPT or fluoxetine. IPT delivered for 3 months because that is a program. Fluoxetine, that is the recommended time of treatment. So we didn't change that. And then, if there is remission, there is no further study treatment, but we follow them up to 30 months. So we have very long follow-up, we're still following up participants. If there is no remission, you are two things happen. You are either randomized to a switch, fluoxetine, or you get both. And then the same happens with the fluoxetine arm. If there is remission, you continue follow-up. If there's no remission, you are either switched or combined. So that is what this whole sequential multiple randomized control trial is about. Now, brief results. Try to be so quick. Okay. So we recruited our first participant on 31st of August 2020, and the last one on the 5th of October, and achieved the sample size. Within 30 months, 2,162. That's a huge sample just around Kisumu County, the nearest place. Because one of the requirements was that you are able to come and attend the session. So you will not be from the other corner of Kisumu County, you cannot say, I'm able to come. So that tells you something. Now, baseline demographics. Some very interesting one is that about 90%, slightly over 90% were female. And what this table shows you is the randomization system, so that you can see that there's no significant difference the two arms, but both of them that you see that over 90% were actually female. That's a huge gender difference. Now, formal education, let's not go too much into that. It is just like anywhere in Kenya with a few guidelines, and where the basic education primary is probably more common, particularly when you have a rural community. Some of our participants are coming from the rural community. So the other thing I wanted to show is the health characteristic, clinical characteristic. More than 50%, no, about 40% were HIV positive. And we did get a lot of participants coming from the cities. And that is not surprising, considering that Kisumu County has something like 17.9% prevalence compared to the about 4% in the country. So that should not be surprising. But surprising, perhaps, prevalence of intimate violence, and that is more than 50%. I've experienced, current, not current, in the last 1 week, intimate partner violence. And when you talk about trauma, you find that almost 90% had more than one, experienced more than one type of trauma. But this worrying trend in intimate partner violence, I think, is something I want you to take with you. Now, we had a very high intention. Of course, as a study, we also have an intention officer. That means if you don't appear, then we call you, we have your number, and we try as much as possible to reach. So it is not like in the normal regular practice. If your practice patient doesn't come, you don't call or you don't ask them for your number and the number of person you trust who I can call you, but don't get you on this number, which is what we do the rejection. We could even go and visit. So that is studies are like that because we're also looking for effectiveness. So we had a very high intention and we also had a very high fidelity in the interpersonal therapy. And also in the work fitting, completion of work fitting session and fidelity and you see all very, very high figures. That also has to do with the fact that this is a study and they make all efforts to make sure you get this done. But the fidelity shows that we've also had in place very clear ways of delivering this intervention. Now, very interesting is our remission uh, rate, which are extreme. As you can see, 6 months after treatment with interpersonal therapy, you will find that only 8% of the participants still had symptoms of depression or PTSD. And 6 months after low treatment, only 4%. And we are continuing this, so we'll be able maybe next time to tell you after 30 months what was the revision rate. We told to wrap up. So let me wrap up. Very quick. I want to show you our disability scores at the beginning and at the end, which is really dropped. Now I'm out of the sociodemographic, but this is one of the things that poverty is one of the social determinants of health. And another one is the economic productivity, which at baseline, the block there is the number of days missed of work. And the last one is 6 months of treatment with IPT, there were only 2 days. After 6 months of treatment with fluoxetine, 2 days. So economic productivity increases with treatment. And this has been shown in multiple studies. And then these are other forms of economic productivity which we also assess. Same story. Now, in summary, our study demonstrates the high unmet need for treatment of common mental disorders, basically depression and PTSD. Like 2,162 participants could be recruited within the period of 13 months. 90% of which are female, 40% HIV positive, but I did mention that we're in an area where the prevalence is high, and 50% experiencing IPD currently. So, in conclusion, what I'm trying to say is that a non-specialized provider can be trained to effectively deliver IPT with high fidelity. Nurses and clinical officers who are not specialized in psychiatry can be trained to deliver modern antidepressants like fluoxetine. This, of course, has certain limitations given the current regulations about who can prescribe what outside of the study, and we are working with that. Now, there's a very high remission achieved with both forms of treatment, almost equal so far, and we had a very dramatic reduction in disability scores and increase in work performance and economic productivity. So the question we are at is what next? Currently, we are engaged in scaling up activities in the county. We're scaling up in several health facilities, but we do have limitations which are very important, and we are engaging and consulting with policymakers. Before I'm kicked out, let me acknowledge the team. And you see some people here who will probably know, and some who don't know. My other PI is Dr. Susan Lefa from UCSF. And this is our Smart Dapper team. If you're here from the Smart Dapper team, just stand up and just wave from wherever you are. Yes, this is our team from Kisumu there. Some of our investors as well. Thank you very much.
Thank you very much.